post the webinar recording. We'll post the webinar recording on our website, and the slides are already there. So if you want to go and take a look at the slides and follow along as we go through this presentation, please feel free. And so today's presentation is on our benefits. We're really excited to finally dive into the weeds on our benefits with all of you. And so you probably remember from last time, we switched things around a bit, and we're going to do 2 benefits webinars. So we have this one, and then we have a benefits webinar in 2 weeks. So we're really excited to just talk about this with you. If you leave today thinking about questions, please feel free to send them to us via email. We can try to prioritize answering some of those questions next time. But then again, also happy to take questions today. And Lindsay just put the link to our slides into chat. So thank you, Lindsay. All right, next slide, please. Okay, I think I did most of this. So today we're going to start again with our program requirements overview. And next slide, please. Sorry. Okay, let me not skip the agenda. So we'll do our very quick program requirements overview. Then we will turn things over to Colette and Arthur from the benefits team, and they're going to talk about the benefits. And then we'll have more time at the end for Q&A. Next slide, please. Great, so you've all seen this before. We're going to just do another quick overview of which specific capacity building application requirements we're talking about today. Next slide, please. So just a reminder, here we are at with our milestones. I think you've all seen this chart before. Next slide, please. And so just another quick reminder, the Milestone 2 capacity building application has the list of all of our program requirements. And then for Milestone 3, to pass our readiness assessment, you'll need to demonstrate in writing how you achieved each requirement. Next slide, please. And so today, what we're talking about is actually we're going to talk about quite a few sections. So Section 5, which is case management, Section 6 of the capacity building application, which is support for medications, Section 7, which is optional additional services. Next slide, please. And just a quick, I'll just do another plug for, we're already halfway through our webinar series. That's crazy. But we're going to have another webinar on services in 2 weeks. And then remember, we switched around a couple of things. So we'll be talking about web resources and the final requirements that we haven't talked about in early March. And then we're going to basically have another Q&A forum. Next slide, please. So we didn't list out all the requirements for this webinar because there are so many, but please know that we're talking about sections 5, 6, and 7 of the capacity building application. Next slide, please. All right, and that's it for me. I'm going to turn things over to Colette.
Thanks, Emma. Good morning, everybody. I'm Colette Jones. I'm a manager in the Medicaid Programs Division here at Healthcare Authority. I'm a nurse by background, and I will be joining Arthur today, who I know you've met before. He'll introduce himself shortly. We are going to present on the Reentry Initiative benefit package and make sure that you have a place to start. There's lots of resources attached to this webinar for you to dig into for more information. Next slide, please. Okay, so here's the big picture, the list of services that are available to be delivered for our clients who are incarcerated and related to this initiative. They're broken down into 2 different categories: mandatory, which is your green box on the left, and purple is our optional services. Just as you heard from Emma a minute ago, we're going to pause the optional services conversation until the webinar on the 19th and focus today's conversation on this green box. What are the required services carceral facilities must ensure access to participate in this initiative? We're going to be talking about all 5 of these today: targeted case management, reentry, substance use disorder expectations, reentry pharmacy, providing medications at release, and then 2 that are specific for consolidated appropriations. Let's talk about that for just a second to make sure that you're seeing how this is coming together. There's really two directives here that we are blending into one initiative for simplicity's sake, so that you all have one initiative to be tracking, not two, and because there's a lot of overlap in the expectations. One is our waiver initiative. You've heard lots about that. You already know Medicaid transformation gives us authority to offer services 90 days pre-release. So that's fantastic. That's why you're all here. Okay, so then we have the second piece. That's Consolidated Appropriations Act, or the CAA, you might hear. This was federal legislation passed in 2023 to afford additional benefits for our juveniles. We're going to talk more about that, but because there is overlap in these two authorities, we're blending them all to support you in knowing what the expectations are and help our state move forward in providing services for incarcerated individuals. Next slide, please. Okay, so I think you've seen this slide before. This one is around what our provider community might look like for serving our incarcerated individuals. They're going to be in various footprints depending on the carceral facility. So if you as the carceral facility have qualified healthcare professionals that are on staff, that's what this first box is intending to convey, that we are looking at in-house staff that are able to provide Medicaid benefits according to Medicaid Apple Health rules. Those are going to vary by service and by provider depending on your own functionality in-house. The second bucket is our most common bucket. This is where we're leveraging our community-based providers. These are healthcare providers that are out in the community doing the good work that they do every day. They may already be serving clients who are incarcerated, but they may not. Most of our community providers are known to Medicaid already and enrolled in the system and so forth, but some may need to be connected here in order to serve our population. The last two buckets are specific to a particular service. Our managed care organizations may have qualified healthcare providers that are able to support our targeted case management benefit. And Arthur will talk about that a little bit more. That is for our managed care enrollees, so specific to that plan. And then the last bucket here is a similar concept for targeted case management. This is the third-party administrator that our agency is working to procure in order to support access for targeted case management for individuals when the first two buckets aren't available. So this is kind of going in order here. Let's see. I think you've already heard, but I'll reinforce from the provider enrollment conversation that happened earlier in January that all of the providers that are qualified here need to be enrolled in Provider One. They can be enrolled as a billing provider or a servicing provider, and there's lots of resources available there if needed. Next slide, please. Okay, so just looking at the benefit package, big picture, there are some core requirements, foundational understanding elements that I want to bring to your attention. So one of these are that we have billing guides that are put forward by Healthcare Authority, Apple Health Provider Billing Guides, that are required to be followed in order for Apple Health services to be billed. There's lots and lots of documents available, lots of information available in our website to support healthcare providers in understanding what those expectations are. We have a lot of hyperlinks at the end of this document to help guide and point you to the right related documents. Okay, so the second concept is medically necessary. Medically necessary is a Medicaid requirement to provide services that are appropriate. It's highly defined and it's available in the WAC for you. That link is at the end of our document as well. But essentially, I want to just talk to you about what that means. We have terms that define this as reasonably calculated to prevent, diagnose, correct, cure. There's a couple more, alleviate and prevent worsening of conditions. So it is our guiding light about what services are needed for clients or not. Okay, so let's talk about our goals. So the whole point of this initiative is to help clients get stability and release with a better healthcare plan in place. We're looking to prevent morbidity and mortality post-release by doing a few different things: identifying healthcare needs, getting clients engaged in recovery and engaged in services, and then facilitating access to those services. We are looking to do this in a few key areas. We're really interested in driving the needle forward and helping our clients with chronic conditions and infectious diseases because of the prevalence in the population that you serve. So specifically calling out substance use disorder, that's a high area of attention for us. We want to make sure we're really supporting this population, especially our population with opioid use. And also mental health conditions, supporting engagement in care and continuing that recovery journey. And then hepatitis C and HIV are some of the infectious diseases I would call out that we want to make sure we're looking at too. All right, so healthcare is complicated business. You know this. And to help guide you in knowing how that fits into our reentry picture, we've created a few documents. Um, the box on the right lists out the key documents I really want to hone in on and focus your attention. The first one is called the Policy and Operations Guide. In that Policy and Operations Guide, which is not yet available, it will be this month. We're working to get all the question and answers embedded in there and get that out as soon as we can. But this Policy and Operations Guide has a section that is focused on benefits, and it is your starting point. This is where you go first to understand how Medicaid benefits aligns with this reentry initiative and what other documents will help your providers know how to navigate that structure. So this is where I would recommend you go first. And then the second list here is another document that is going to be published really soon in this month that lists out the codes that are allowable within the reentry initiative. Healthcare is all about coding, right? That's how the system is operated. And so this is your light on which ones are allowable. This helps your provider community know whether a service is covered or not covered. So that is also very helpful for your healthcare providers. Then there is a whole lot of other documents that I mentioned already that are copied into the appendix for you to dig into. But those are the documents that point you to those resources like the billing guides and fee schedules and so forth. So lots of resources for you to dig into later. I do also want to call out that in the appendix, it also describes the inpatient coverage that exists today. We have the ability to pay for inpatient hospitalizations when they're over 24 hours stay, and that information is available today. It's an existing capability. There's no change to that structure based on this initiative. Okay, next slide. I am going to hand it over to my partner, Arthur.
Hi, everyone. A lot of you have seen me before presenting in here and other places. So my name is Arthur Andrews. I'm an occupational nurse consultant here at the Healthcare Authority. My focus is reentry services, and I work very closely with Colette and Emma's team in developing the benefits section of this. So we're going to be talking about a couple of different things in this webinar in particular, and particularly with targeted case management. We'll be talking about SUD treatment, and we'll be talking about the mandatory pharmacy as well. So the first thing that we're going to be talking about here is reentry targeted case management. This is a mandatory service that facilities must provide in order to, if they're going to participate in the waivers. So next slide. And getting into this, this is, again, this is a mandatory service. This must be provided 90 days in the pre-release period. And then also in the post-release period, there's some interaction there with the CAA as well with 30 days versus medically necessary too. So essentially here on the reentry targeted case management, it starts at booking or intake with that initial health screening. Many jails are already doing some kind of intake or screening now. And so this is really kind of identifying the need, identifying that the individual wants to participate in targeted case management services, and that's a really kind of important concept of this is a mandatory service for the facility to make available and to provide, but there's always freedom of choice in the individual. So the individual always has the right to participate in treatment or to deny services. And so if the individual says they don't want to participate in this service, they have that right to do so. So I know that question has come up in the past. And so that's always a driver. We're not compelling anybody to participate in healthcare services. It just needs to be made available to them, and they have the right to refuse or to participate as they wish here. So really that health screening is to identify those healthcare needs, identify that they want to participate in case management services, and then forward them to the case management services of whoever the facility has identified is going to be providing those services. This is in the 90-day pre-release period. Right now there's going to be some more information. There was a webinar earlier previously on what that looks like. And so really that 90 days for most jails, for the jails in county jails and city jail setting, is going to start at that booking time frame, right? And that's going to capture most individuals. And so that targeted case management is really then going to get into those more comprehensive assessments, right? We're talking about a holistic viewpoint and a holistic view of the individual to include physical needs, behavioral needs, SUD needs, maybe some health-related social needs, and just an all-encompassing viewpoint and with a comprehensive assessment of that individual. And then, we're going to talk about in the next slide, we'll talk about the requirements, but there's really some key points here that we really want to point out. So this is available 90 days pre-release in that 90-day pre-release setting. And then it's available as medically necessary post-release. The CAA does call out a 30-day post-release period, but these kind of overlap and align. And so the service is going to be available as medically necessary. There are some requirements and licensure requirements to provide case management services. So because this does include a comprehensive assessment, there is some licensure requirements for the individual who will be overseeing the targeted case management. So we've identified the roles that can do this, that it's within their scope of practice, and those roles will be spelled out in the P&O guide that's coming out. But some of those examples really are licensed independent social workers, registered nurses. There are some licensed mental health counselors, and there's some other individuals in kind of that encompass in that behavioral health world that can do these sorts of things. So, I really want to kind of point that out, that there are some licensure requirements here because it is a comprehensive health assessment. It is a social worker centric comprehensive assessment, but registered nurses can certainly do this. And calling that out because as a nurse myself, when I hear comprehensive assessment, I think head to toe assessments and those types of things. But this is really an inventory of the individual's holistic health needs and in developing a care plan based upon that. So the other thing I would point out here is there's going to be information coming out on how the billing is going to work and how that is going to flow. But the way the billing is going to flow is the individual who's going to be providing targeted case management services needs to be enrolled in P1 as a servicing provider. So I'm calling that out because I know, that is not a typical way that nurses kind of go when they're doing this. Just calling out that nurses will need to enroll as a P1 servicing provider so the billing can flow right, so they can be attached to the billing. That also applies not just to nurses, but anybody who's going to be providing this service as well, because you'll need to submit with their taxonomy. That is not, I've been involved in a couple of conversations where that's not the typical thing. As a nurse, I certainly know when I do case management services, typically I'm working beneath a provider and they're billing based upon that. But in this case, for these services, the licensed individual who is providing or overseeing these services will need to be enrolled with Medicaid as a servicing provider. Next slide. So what does targeted case management really entail? So we've talked about the reentry health assessment. So this is about pre and post-release care needs, not just pre-release care needs. This is about connecting that individual with those post-release care needs and getting them connected to those services. It is going to be required if they haven't had a reentry health screening, or if they have unmet care needs that have not been addressed. And based upon that health assessment, a care plan will need to be developed. This is pretty typical in the workflow of licensed individuals who are doing these comprehensive health assessments. This is very much a normal process for nurses, for registered nurses and licensed social workers to develop care plans. And then, that care plan should be person-centered and actionable, right? So it should include, what are the care needs, what needs to be addressed, and the care plan should drive the work moving forward for that coordination services. That coordination is also, that's going to require, coordinating care to linkages to services post-release, whether that's, physical, behavioral health, health-related social needs, whatever services they need connected to on the outside. That's where the case manager would step in and start to make those appointments and start to provide those linkage services and do that follow-up as well. And there will be a warm handoff. So this is also pretty typical in the workflow, but I know that the way that it's described in the correctional setting can be different. This is a healthcare related warm handoff, a person-to-person handoff. If that care manager is going to change pre and post-release, it may not, depending on who your facility is identified is going to provide those services. So, but if that care manager is going to change, they need to do a warm handoff to the next care manager so they can get a copy of the care plan. They know what's been done. They know what's outstanding, and that work can continue and not start from scratch, right? So I used to be a correctional officer. I did warm handoffs as well. We just called them pass downs. When my next person would come and relieve me, from on shift, I would give them updates, introduce them to the logbook. What have I done? What's outstanding? What's happening? Any weird occurrences? All those good kind of things. And so this is kind of the same thing. Just it's healthcare centric from case manager to case manager. Next slide. So the next thing we're going to talk about here is SUD and pharmacy. We're going to kind of combine these two things, but I'll call them out as they are two separate benefits, but they do interact very closely. So these are both mandatory benefits that must be provided to participate. So these would encompass the second and third mandatory benefit that you must provide, targeted case management, SUD 90 days prior to release, and then the pharmacy benefit, which is 30 days of medications in hand at release. So next slide. So let's talk about what this looks like. So we're talking about the identification of an SUD need when the individual comes into booking most of the time, right? There's going to be some nuances there, long-term stays, 90 days pre-release. I know that's going to look different for DOC and some of the long-term stays that could be in the county jails, but I'm just calling out that for most jails, that 90 days pre-release is going to start at the time of booking. We've recognized that there's going to be some time frames that we need. What are realistic time frames for this, right? And so that should be available in the P&O guide of what those time frames will look like and what the expectations are to provide these services. right? Like, for instance, if a jail books and releases somebody, do they have to do all these services? Well, the answer is no, right? There's going to be some realistic timeframes built in here, based upon discussions that we've had, both externally and internally, trying to navigate what is clinically appropriate, what is realistic, what are jails doing now, and those types of things. And so there will be some clear expectations in the timelines of when these things are required. But really what we're talking about here is, I just want to call this out, that we're talking about a clinical evaluation that can be done by a provider in the facility, or whatever provider you've identified is going to be doing this, and making sure that you're addressing the individual's SUD needs to get them started on the initial medication and get that going, right? And then, we're calling out MOUD and MAUD medications, so opiate use disorder and alcohol use disorder a lot here. You'll see that called out, but this is really SUD treatment for all substance use disorders, right? We're calling those two things out because those are the two big ones, and those are the kind of driving forces here. So, but really, it's whatever the individual. There are other SUD, issues out there that need to be addressed with individuals as well, outside of opiate use disorder and alcohol use disorder. So this also, includes, when we're talking about SUD, we're not just talking about medications, right? We're talking about, connecting them to treatment and making those linkages and getting that going and getting that started for them when that's appropriate to do so. So, you'll be seeing the code list when it's released. We've left this pretty wide open if it's appropriate and we have the authority to be able to provide this through a Medicaid services. We've left it open and tried to make sure that it's available for a jail to provide if they want to. And then, that pharmacy medication at release. Talking about SUD and pharmacy, they kind of go hand in hand here. The requirement is 30 days in hand of pharmacy medications at release, right? So calling out that it's not just SUD medications, but it's all Apple Health covered medications. And so whatever pharmacy that you're utilizing needs to be aligned with the Apple Health preferred drug list. Some of the one of the timeframes that we provided here that will go into more depth in the P&O guide is that at a minimum, that's for clients who are incarcerated longer than 2 business days, right? So 2 business days or longer, then we should be providing them medications at release that 30 days in hand. There are some instances where this may not be completely appropriate. For instance, there are some SUD medications where there's a taper. You give them 7, then you give them 14, you give them 28. That's completely appropriate. Also, you're not going to hand somebody, a 30 days worth of medications if the provider needs to start them on an antibiotic and it's a 14-day course, right? There's also going to be some guidance in there about, time frames and what that looks like. And, what happens if the individual, discharges unexpectedly versus expectedly, and those types of things, and some realistic time frames on that as well. I do want to point out that, that there is some clinical appropriateness here, that the provider can use. Is it always appropriate to provide 30 days worth of medications? And the answer is no, it's not always clinically appropriate, but it also needs to align with the Apple Health preferred drug list and the Medicaid rules when doing that, right? It's not, arbitrarily just saying, hey, I'm going to give this much medication. It's really about getting them the medications they need, getting them connected to the next level of service, and really, CMS has lined out that it's really a 30-day supply of medications in hand. We've identified some areas where that may not be possible, and so what to do in those situations. Next slide. That SUD evaluation. I think we've talked about this. Carceral facilities must provide access to a qualified provider who can evaluate, assess, diagnose, and prescribe treatment for SUD. It could be a correctional healthcare provider. It could be a primary care provider. Whoever that is that your facility has identified who is going to be able to assess and start those medications and get them going on that treatment, in a realistic, I don't want to say realistic, but a clinically appropriate time frame, right? So This does include screening, assessment, and evaluation of health conditions. Calling out that there's a difference between an SUD assessment and that initial clinical assessment to get them started on medications, right? So what we're not saying is that, as soon as the individual is booked, you have to do a full SUD assessment. It's about that clinical assessment and getting them started on medications. That diagnosis, provision of treatment to stabilize and control, right? And then recommendations for pre-release treatment and services and post-release treatment and services as well. Next. And then, talking about the medications. So what is required here on the SUD side of medications, right? So carceral facilities must provide that access to appropriate SUD medications 90 days pre-release as medically necessary, but it must align with the Apple Health preferred drug list, right? So, and the policies that surround Medicaid and the preferred drug list. So, I could list all these and name these off. I'm not going to go through each one of these. Just know that there are some minimum requirements here that we've set that you must make available in your facility for the treatment of SUD treatment for medications. And it does include professionally administered drugs. So those long-acting SUD medications that require an injection, those types of things, those drugs are covered as well and can be billed to Medicaid as well. So and really calling out here that this isn't just about treating the SUD issue and the withdrawal symptom. This is about treating the withdrawal symptoms as well, right? So not just treating the SUD dependence, but also addressing the withdrawal symptoms that come with that. So, we're talking about pain, nausea, agitation, anxiety, abdominal cramping, hypertension, tachycardia. Those are common withdrawal symptoms that you'll see, and just really calling out that at a minimum, we're calling out some minimum requirements to treat withdrawal symptoms as well. Next slide. And then the medications at release. So medications at release, it's a 30-day supply in hand. We've talked a little bit about that this is for those who are incarcerated 2 business days or longer. There are some other instances that will be called out about what's appropriate for those unexpected releases, what to do in those situations versus expected releases. But at a minimum, the pharmacy that you're using must be aligned with the Apple Health preferred drug list. And so they also must be able to bill for medications through the point of sale system, which is a Medicaid requirement to be able to provide medications and bill for medications through Medicaid, right? So, also, understanding that there's some clinically appropriate rules built in here. It's not always clinically appropriate to provide 30 days of medication in hand, but that needs to align with Medicaid rules as well. So, and that preferred drug list. This does include professionally administered drugs. We're talking about those medications that must be administered by like a nurse or a provider. And that does include vaccines as well. So vaccines was particularly called out in the Consolidated Appropriations Act, which Colette is going to talk more about here in a moment. And so we aligned that with the waiver work because there's some overlap and whatnot there. So vaccines are included here. So, and then that 30 days of mandatory length, I've talked a little bit about this. So some of the examples where this may not be appropriate to provide 30 days, contraceptives is a good example of the other way. There's requirements to provide more than 90 days of or more than 30 days of the medication, right? Excuse me. There are some that are prohibited by law, such as, methadone in more than 28 days for OUD. There's usually a taper up. If you're starting somebody at 7, 14, and then 28 days. So if that's clinically appropriate and prohibited, then you would provide what's appropriate, right? And document that. And then that clinically appropriate, which I think if it's clinically inappropriate to provide more than a set amount, that's also there as well. So. Next slide. And I think I'll pass it off to Colette.
Thanks, Arthur. Appreciate that. So just a status check where we are. So we've covered 3 of the 5 mandatory services: targeted case management, reentry substance use disorder treatment, reentry pharmacy at release. Okay, so now we have 2 more. 2 more are around the Consolidated Appropriations Act. So just as a reminder, this is that federal legislation that gave us an additional pathway to serve our juveniles, right? In that legislation, there was 2 pieces, which you may or may not be aware of. One piece is states, yes, you must go forth and implement this. And then the other piece is an optional pathway to provide more services and coverage for our juveniles. Washington State has opted in to provide as much supports and services using Medicaid funding for this population. So that is one of the pieces we're doing. Both of those we'll talk about. The other is good to know that there is timelines set at the federal level. And in Washington State, the way we're doing this is we are combining this into our Reentry Initiative, waiver initiative, and we are phasing this in. I know that's been a lot of question. We've gotten a lot of confusion and questions. So we're tucking these in together, implementing them together. So that'll be through our phases, through our cohorts, through our participating facilities. Okay, next slide. Okay, so I introduced that there are 2 pieces of the consolidated appropriations, and we're going to talk about that here in the green grid. But first, just to make sure that you are aware of what population I'm really talking about, this legislation allows certain additional benefits for incarcerated juveniles, I'll say loosely, youth and young adults. So this is our 0 to 20 population, 20 and younger, and under age 26 when they're eligible for Apple Health under a specific eligibility group called foster care alumni. This is a eligibility group that means the youth was in foster care at the time they turned 18. So it's a specific Medicaid category. So both of these are rolled up. You'll hear us talk about CAA eligible. So that's what I mean is this, both of these age groups. Okay, so the 2 pieces that I keep referencing for the consolidated appropriations are pre-adjudication and post-adjudication. They're differentiated that way. And we're going to talk more about that handling in the next slide, please. Okay, so first I'm going to start on post-adjudication. Post-adjudication, you're going to see a lot of similarity in this slide from what you just saw in Arthur's slide. So let me kind of roll that up for a second. We have this concept in this reentry initiative called clinical assessment and evaluation, and you're going to see it 3 different times. The first time was, as Arthur just introduced it, in the substance use disorder treatment. That's a mandatory requirement to provide access to medications for substance use disorder. Okay, so that's one. The second mandatory is this one. This is providing juveniles with clinical assessment and evaluation services. And then the third one we're going to talk about in our next webinar. That is an optional service that allows this same service be available for adults. Okay, so what is this thing? This is essentially making sure that our juveniles get care early and timely, get evaluated, what conditions do they have, get screenings, get a diagnosis, get a plan in place to help support them for release. We can talk about that a little bit more, but essentially this is early care for juveniles, right? And I will also call out that our timeline here, you're going to see some different time frames, and that is due to that federal legislation coming in being prescriptive about the minimum time frame to serve this population. You see in the blue box that it's 30 days prior to release and no later than 7 days post-release. That's good to know, but what I want to call out is this tucks into our waiver initiative, allowing you to provide that as early as 90 days pre-release and has this floor as no later than concept. So I don't want to get too worried about this particular time frame of the 30 days. Keep that 90-day timeline in your head. That's where you're shooting for, and ensure the follow-up post-release is to ensure kids are actually connected to care, because they do come in and out quickly, right? You have immediate releases that you haven't been able to do this full array of work. So this is allowing those services to be available for those juveniles within that 7-day window post-release. Okay, next slide. Here's some key concepts around that clinical assessment and evaluation. The main point of it is to help support creating a reentry care plan that's really the pathway for release to help stabilize and so forth. These services can be delivered by a treating provider or a new provider. This can be an established provider that the client already works with, their primary care provider or a specialist perhaps, or it can be a new provider, the carceral facility provider, a local provider who is available, whatever is going to best meet that client's needs. The third one is that time frame concept. This is just reinforcing that we're talking about that 90-day window pre-release. And then the fourth concept I want to introduce is a Medicaid-centric concept that you might hear about called EPSDT. This affords a greater benefit for Apple Health clients than we see in the adult population, and it is specific to clients that are 20 and younger. EPSDT is just as it is in the name, early and periodic screening, diagnosis, and treatment. Essentially, early care, timely care for kids, making sure that we're identifying conditions and getting them addressed so they're not going to be lifelong issues. The CAA does specifically call out two elements of that care. One is getting a well-child check scheduled and getting that connection to primary care. And the other is getting immunizations, so that both of those are expected within this, getting clients scheduled and connected, getting vaccines in arms, and helping them get caught up in their routine care. Okay, next slide. Okay, so then I'm going to dial back in time to the pre-adjudication phase, right? So we just talked post-adjudication. This is pre-adjudication. And this is an interesting one. This allows us to provide a broader array of benefits to the population than we've been talking about. The rest of the slides have been talking about the limited package, the targeted pre-release services available in that pre-release phase. Pre-adjudication allows us to provide a broader benefit. This allows us to provide services that are medically necessary. Again, that concept of medically necessary, and then what are appropriate for this incarcerated youth to make sure we're really honing in on the things that this population needs most. Examples of that are in the blue box for you, but you could tell me this too. This is kids that need mental health screening to get connected to care and services. This is a substance use disorder evaluation to get connected to the carceral facility medical provider, the OTP, the PCP, everybody pulled in to help make sure that that kid has a treatment plan for substance use. And then physical health is also parts of this, especially thinking about a kid that has asthma or diabetes, wanting to make sure that they're having the appropriate medical oversight there. Next slide, please. Okay, that pulls us out to the end of our webinar. And before we jump into Q&A, I just want to kind of summarize where we landed, because that's a ton of information. So just remember that we're talking 5 reentry mandatory benefits: targeted case management, SUD, pharmacy, and then the 2 CAA. Those are your mandatory. We're going to talk about the optional ones. We're going to come back to this at the webinar on the 19th to help come back around to the complexity of the information here and make sure your questions are being answered. We're going to dig into a little of these pieces along the way. We're also going to talk about the time frame that Arthur introduced. What does this look like in a client that is in and out really quickly? What does this look like in a client that is incarcerated for a longer period of time? What's the expectation about when these benefits need to be delivered? So all of that is planned for the 19th, and we will have more documents and more information available for you at that point. Okay, I will stop talking and I will hand it over to our planning team. Thanks.
Thank you so much, Colette and Arthur. That was such a great summary. I'm going to look to Michaela to help us out. Where should we begin with questions today?
Yeah, I'm gonna jump around a little bit. I will go ahead and start with the question about the readiness assessment, which is there a template for completing the milestone 3 readiness assessment so we can begin detailing our program? And there's a little bit of back and forth. So go ahead, Emma, if you'd like to explain that.
Thank you for that question. It's such a great call out. I think it's a good flag for us. We're going to update that milestone chart for our next webinar to include a more accurate date. But we are currently working on our readiness assessment template. So there will be a template that you complete. It will look a lot like our capacity building application. There will essentially be some attestations, but then some space to do some actual narrative writing. So more on that coming soon, but we do not expect that that document will be released until I think we're targeting the week of March 10th. So that's when the document will be released. And then because this is definitely coming late to everybody in cohort 1, we're probably going to be a little bit more flexible with that deadline, which we will have passed. So ideally, if folks could get a document back to us by April 1st, that would be lovely, but we're going to ask the facilities work at the pace that they need to work to be successful. So we can talk more about that when we release the readiness assessment. And yes, that deadline is going to be updating for cohort 1. So thank you for that flag. Back to you, Michaela.
Great, thank you, Emma. So we have another question. I know this is one Arthur wanted, and it's not even a question, it's a statement, but I know Arthur wanted to address. The statement says on page 5 of the attestation, it addresses delegation of case management from clinician to non-credentialed staff, also on slide 18 of the December 11th webinar.
Yeah, I want to make sure and address this too, because that's a good call out, Jody, and I appreciate that call out. Although the comprehensive assessment in the targeted case management, it needs to be completed by a licensed healthcare professional, right? It's within their scope of practice to do so. We are encouraging a team model here, right? So you could have an RN overseeing some non-licensed staff or some licensed staff where it's not within their scope to carry out the work and help inform that work. I could give you a great example of that. So, I have a lot of experience in the ER setting where as an RN, I worked very closely with LPNs. And with LPNs, it's not within their scope of practice to do comprehensive health assessments, but they could go assess the patient and then I could sign off on their assessment as an RN. And that's me taking responsibility for that assessment, right? So I think that's something that you will have to navigate as a facility. What does that look like? But the ultimate, we're encouraging a team model. Not everything needs to be done by a licensed staff, but ultimately the comprehensive health assessment needs to have oversight and sign off by somebody where it's within their scope of practice. So it's feasible you could have an RN or a licensed care worker, one of these roles that we've identified overseeing, the work that's being done by non-licensed staff, and they would just have to take responsibility within their scope of practice for that. So does that help?
Yes, that helps. Thank you.
Yeah.
Awesome. Thank you, Arthur. We're going to go ahead and move on to the next question. Can HCA elaborate on why the clinical assessment and evaluation benefit is listed as only being applicable for post-adjudication eligible clients? It was my understanding that the CAA clinical assessment and evaluation benefit should be offered to all CAA eligible clients, including both pre-adjudication and post-adjudication eligible clients in the pre-release period.
Colette, would you like to take this one?
Yeah, I can take that. Thanks. That's such a great question. So I want to I don't know, can we go back to the I believe it was the last slide on post-adjudication, pre-adjudication, this one. Okay, so in this, this is that broader array of benefits and coverage. This includes clinical assessment and evaluation. This allows access to screening, evaluation, all the good things that we are just saying. So it is yes, both for pre-adjudication and for post-adjudication. That pre-adjudication bucket is bigger about what we can provide in that setting. Thanks.
And did that response, was that helpful?
Yeah, thank you.
Okay, great. Thank you so much. Sorry, just going through the list of questions here. This is more of a statement that may spark some conversation. As far as I understand, methadone must be administered by a specific provider outside, and take-home doses are determined by the methadone provider. I think this sort of gets at that 30-day pharmacy benefit, as well as who exactly is licensed or able to prescribe that.
I just want to call out that for the purpose of this benefit, that we're really using methadone as a good example of, there are some restrictions around methadone. So you don't have to, we're not prescribing that you have to hand somebody 30 days of methadone when they're released. It's just an example of there are rules around methadone, who can prescribe, how much they can get, and all those things. And all of those rules still apply.
I would also put a plug in for the next webinar where we're going to talk about what the pathways are to ensure that you do have methadone access for the clients you serve. We'll talk about that delivery system and what the capabilities are that are currently out there. But just as Arthur said, the current rules do apply.
Yeah, and I see, Jody, your comment there, methadone for youth. I'm going to be really honest. I'm not an expert in that realm, so I can't really answer that question. So.
Yeah, I think we could take that back to see the specific age that's appropriate for, but I think we have the term juvenile also referring to our 18 to 21-year-old population, depending on what aspect we're talking here. That CAA uses the term juvenile to include adults as well.
Okay, thank you. And this next one, I think, is maybe going to be oriented towards Colette. It's a question, will you have another webinar when the billing guides and fee schedules come out? And I think this is less about whether or not we're going to have a webinar and more about what exact guidance are we going to be able to give, and how much are we going to be able to help around this particular issue.
Yeah, thanks for that question. So let me kind of walk through what information is available at what point. So today there is a ton of documents that are attached to this webinar that are available for you today. Most of the benefits that we're administering through this program are already up and running. They're already existing benefits. Community providers are doing this day to day. The only one that's new that I would call out is targeted case management. That one is new, and that is, as you heard Arthur describe it in summary today. That one will have more information available for details. But what the new piece that we are going to be releasing this month is kind of a guidance document. It's what is this thing? What does this mean in a reentry setting? And how does the usual benefits fit in here? That's the policy and operations guide. That document is going to be released in February, along with the list of codes that is the explicit covered, non-covered, here you go. Those documents are going to be your guiding light of how to navigate. And we are going to be connecting again on that meeting on the 19th to support you understanding how to navigate. And then we have room in future webinars if we need to pull in more specifics. I think we can take that question back and see how to address that for the team. Thanks.
Awesome, Colette. Thank you so much.
Sorry. Oh, I'll just do a quick add-on to that. So appreciate the question about just more webinars in general. Right now we have the schedule that we've been sharing with folks, but I don't think that necessarily means that we won't have more webinars in the future based upon the types of questions or concerns that we're hearing from facilities and the need for more information. So more could possibly be coming. We will eventually move back to our once a month just check in. And so we'll also be able to bring content to those monthly check-ins as needed. And then we are aware of at least one or two more webinars that we're going to plan for in the future, in particular around our claims clearinghouse, which we're not able to schedule yet, but we will be scheduling for a future date. Thank you, Michaela.
Hey, Emma, since you're referring to the claims clearinghouse, can you just say what a claims clearinghouse is?
That is the vendor that we will be using to help facility-based providers process claims for the program. So more information to come on that in the future. We're just not ready to talk in more detail about that because that person is not on board yet.
Thank you. This is a question for Emma. Will the updated / modified cohort 1 timeline impact the intended July 1st start date, including delays in funding delivery?
Ideally, no. I think that what it does mean is that facilities that want to start in July will need to try to turn that document around as quickly as possible so that we can review it. So it might be worth considering blocking off some time on the calendars of your team who will help with your facility response for the last 2 weeks of March so that you can get that done and turn back around to us as quickly as possible. But I think you can plan, you can really do a lot of planning for that by looking at the attestation statements in the capacity building application and thinking about how you would write out an explanation of how your facility is meeting each requirement.
Thanks, Emma. Okay, we only have 1 minute left. So Arthur or Colette, are there any questions that you saw that you'd really like to address? Or Arthur, I know you were saying some things in chat, if you'd like to elaborate at all on the prescription pharmacy benefit. Arthur, you're muted.
I'm sorry, just to clarify that 30 days of medication, like if somebody's rearrested or they say they lost their medication, normal Medicaid refill rules apply and clinical judgment there, right? So there are already checks and balances in place for when you can do that and how you can do that, and those normal rules would apply. We know that absolutely happens. You know, I worked in the ER for 10 years and that absolutely happens, but there are checks and balances and safety valves in place for those instances now, and those normal rules would apply. You know, Dawn elaborated, you know, if somebody's getting transferred to another facility, are these medication responsibilities the responsibility of the receiving agency? And I think that depends on the benefit. If it's 30 days in hand, that would be the responsibility of the releasing agency as the individual is leaving incarceration, right? But if you're talking about SUD medications and providing those, then the normal timelines would apply that are going to be outlined in the P&L guide. So.
Thank you so much, Arthur, and everyone for your time. I know we're a little bit over time here. Emma just wanted to point out some of the resources we have here that, you know, can potentially help with some of these questions and help you get started with enrollment, which we all know is a key component of getting this process going.
Great. Yes, thank you, everybody. We do have so there's an appendix for today's webinar with a lot of links to the different resources that Colette was talking about earlier, Colette and Arthur. We're going to pick this back up. We'll have an FAQ for these benefits webinars. We'll try to revisit questions that didn't get asked today. I know we're a little over time. Thank you so much for your time today, and we'll pick this back up in 2 weeks.
Thank you all so much. The appendix is in the benefits slide. It's just at the end. We didn't click to it quite yet.
Michaela, Colette, Arthur, Emma, thank you so much.
Thanks, everybody.